Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. Today's live stream is about 5 signs ICU doctors are giving up too early on your critically ill loved one in ICU and what families can do about it. Good morning, everyone. Welcome to this absolutely critical live training. I'm so glad you're here with me. Today is Sunday, 28th of December. 10:30 a.m. Sydney, Melbourne time. It is 6:30 p.m. on a Saturday, Eastern Standard Time in the US, and it is 3:30 p.m. Pacific time in the US on Saturday, the 27th of December. I do these YouTube lives every week around the same time, and I want to welcome everyone. And I can see some people joining. I also want to welcome our viewers on replay, and because I know we're getting quite a good number of replay views on this channel. So if you can see and hear me clearly, type yes in the chat right now and tell me where you're joining from. Are you joining from Australia, from the UK, from the US, somewhere else, from India? I would like to know. So today we're covering something that will literally save your loved one's life. 5 signs ICU doctors are giving up too early and what families can do about it. This is information every family with a loved one in ICU needs to know. And in the second half, I'm going to show you evidence-based alternatives that most ICUs will never tell you about. But before we dive in, 3 quick things. Number 1, hit the subscribe button and the notification bell right now so you never miss these critical trainings. And subscribe to my YouTube channel if you want to get regular updates for families in intensive care, and share this video with anyone who has a loved one in intensive care. I do these live sessions to give you information that nobody else will give you and that will change the outcomes for your family. And that is evidence and documented on our intensivecarehotline.com testimonial section or on our intensivecareathome.com testimonial section. We've also done client interviews on podcasts, and you can find that again on our intensivecarehotline.com podcast section. So share the video, subscribe to my YouTube channel, like, comment, and subscribe. So also tell me about what brings you here. Do you have a loved one in intensive care right now? Or have you had a loved one in ICU knowing you had this information at hand when you needed it? I want to know who I'm speaking to today. So let's get right into it. Today's agenda is very powerful. The 5 warning signs that ICU doctors may be giving up prematurely on your loved one and the specific questions you need to ask. And the second 30 minutes will be evidence-based home care options for tracheostomy and ventilation at home that provide better quality of life than hospital, even for palliative care. So you will see real case studies and action steps you can take today. So let's go. And also, if you wondered what makes me qualified to host a session like this, again, my name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. I am a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse unit manager for over 5 years in intensive care. I've been consulting and advocating for families in intensive care all around the world since 2013 at intensivecarehotline.com. I've been the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we're providing home care for long-term ventilated adults and children with tracheostomies, home BiPAP, CPAP, ventilation without tracheostomy, tracheostomy without ventilation, cough assist management at home, ventilation weaning management at home, home TPN, home IV potassium, home IV magnesium, home IV fluids, and home IV antibiotic infusions, central line, peak line, Hickman's line, port cath management at home. We're also providing PEG, patch tube, nasogastric tube, nasojejunostomy tube, and catheter management, IDC and SPC management at home, as well as palliative care. So we're also providing level 2 and level 3 NDI support coordination, as well as TAC and WorkSafe case management. Now, let me start with a story that happened just last month, but it also happened numerous times over the years. Like I said, I've been here on YouTube since 2013, and if you go back through my history, you would have heard me sharing many stories here where we have saved lives, where doctors were trying to stop life support prematurely, and clearly we were able to turn it around and save lives. So family contacted us at intensivecarehotline.com. Their husband and brother-in-law, 51-year-old at the time, had been in ICU for about a week or so with a hemorrhagic stroke. And the ICU was adamant to stop life support. Doctors called multiple family meetings and said, there's nothing more we can do. We should consider stopping life support because we don't think that your family member, even if they do survive, will have any quality of life. Right? And they were also told, oh, he's going to die today. He's going to die today. And well, he didn't die. So then you have to question clinical judgment, and then you have to question their motives. But the family still felt very helpless. They felt like they, on the one hand, had to accept it, but something just didn't sit right with them. And then the patient's brother called me, and, I actually then, because it was local, I then actually met them in person. A lot of consulting that we do is over the phone or on video or whatever, but that happened to be here in Melbourne, in Australia. And, I went to meet the family. It was at a local hospital. And, we were able to turn this situation around. We advocated successfully for a tracheostomy, and he had a tracheostomy, and they were still very negative, saying, oh yeah, tracheostomy won't change the outcome. He's going to die, blah, 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 and maybe a few months later, he had the tracheostomy removed. And he was licking on an ice cream, and the family showed me pictures, right? And it's amazing, right? And you always have to come back to evidence, and evidence shows that 70 to 90% of intensive care patients survive. So the odds are in your loved one's favor. And, the odds are in your loved one's favor. If you're watching this right now and you have a loved one critically ill in intensive care, and the ICU team is telling you there's no hope, your loved one's going to die, be reminded, let me remind you that the odds are in your loved one's favor, right? I can give you another example where, family has called us, and they had a family member in intensive care for 3, 4, 5 weeks with pneumonia and respiratory failure as part of MND, motor neuron disease. Again, doctors called family meetings saying there's nothing more we can do. You should consider stopping life support. Initially, the family felt helpless, and they thought they had to accept this. But again, they were starting to advocate and saying, hey, no, we want a tracheostomy. We want to take my husband home with intensive care at home. And today, that husband and father is at home on a ventilator with 24-hour critical care trained nurses, having community access, having community outings, and that is a gentleman with motor neuron disease, and he's been home for over 5 years now. So that is what we're talking about today, because here is what families in intensive care don't know. Medical bias, hospital capacity pressures, financial pressures, staffing pressures, And lack of knowledge about home care options such as intensive care at home means that families are often presented with a false choice. Either your loved one gets better and goes home independently, or they die in hospital. It is such a limited mindset, right? It is such a limited mindset where it's black and white. You either leave ICU and you survive, or you die. Very black and white, very limited mindset. The good news is today I'm also here to explain you again about the third option that most ICUs are still ignorant about. ICU doctors, ICU nurses still ignorant about, either don't know about it or won't tell you about. And, and this third option is intensive care at home, right? So type in intensive care at home if you are interested in that option today as well. And Luna, thank you and welcome from Palos Verdes in California. So we've got an international audience here. That is amazing. Welcome, Luna. Now, before anyone gets defensive, I'm not saying ICU doctors are bad people. I'm not saying ICU teams are bad people. I've worked in ICU for 20 years myself. So I know the good, the bad, and the ugly. I've worked alongside brilliant intensive care consultants. I've worked alongside, brilliant intensive care nurses in intensive care. Now, we're employing 150 intensive care nurses now here at intensive care at home, right? So I know all about my professional peers, right? Because I work with them every day and I have been working with them for the last 25 years. But the system, which is intensive care, has limitations, biases, and pressures that can work against your loved one and your family. And today I'm going to show you exactly what to look for and what to do about it. And if you're getting value already, click the like button so this reaches as many families who need it right now. And thank you, Luna, for letting me know that you are interested in intensive care at home. Okay, so let's look at the 5 signs that doctors and nurses in ICU are talking about withdrawing treatment too early. Sign number 1 is premature end-of-life discussions. So, all right, let's get into sign number 1 that ICU doctors might be giving up too early. End-of-life discussions are happening before aggressive treatment options have been exhausted. Here's what that looks like. Your loved one has been in ICU for 1 to 2 days, and they're on a ventilator, maybe on some medications to support blood pressure, such as inotropes or vasopressors. And the doctors call you in for a family meeting. Red flag phrases you might hear. Well, the first red flag is straight away that they're asking you for a family meeting right away. Red flag phrases you might hear is quality of life will be poor, or your loved one won't survive, or they're not showing improvement, or they say we don't think your loved one will get back to how they were. Or they say things like, the kindest thing would be to let them go peacefully. Now, listen carefully. Sometimes these discussions are absolutely appropriate, but sometimes, and most of the time, from my extensive experience, they happen way too often. Here's what you need to ask. Is your critically ill loved one in a real or in a perceived end-of-life situation? What's the difference? Well, I'm glad you've asked. A real end-of-life situation is that nothing whatsoever, no treatment, no medications, no life-saving surgery, no fancy equipment, no nothing will save your loved one's life, and they're going to die in the next few hours. That is a real end-of-life situation in intensive care, hands down. Anything out of that is a perceived end-of-life situation. Maybe there's hope. Maybe, we can do treatment. Maybe we can do surgery. Maybe we can give this medication. Maybe we can just try and buy some time by putting in extra support, right? That's a perceived end-of-life situation. The perception is that, your loved one may die, right? But that's just that. It's a perception. And as long as it's not real, you should be pushing along, assuming that's what you want for your loved one, and assuming that's what your loved one has asked you to advocate for, when they could still advocate for themselves, right? So real versus perceived end-of-life situation, extremely important to make that distinction. Now, And like I said, when it's a real end-of-life situation, these discussions are appropriate. But most of the time, from my experience, they happen way too early. And here's what you need to ask. Has your loved one been offered a tracheostomy evaluation yet? Right? So for example, I gave you the example in the beginning where this 51-year-old man was in ICU with a hemorrhagic stroke, and ICU said, oh, let's just stop everything. He won't survive. He won't have any quality of life if he does survive. Now, when the family contacted me, I said, well, have they explained to you the option about a tracheostomy? And they didn't, right? So again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly what you're up against. So if ICU hasn't talked to you about a tracheostomy as an option, then they're already misleading you. Even if it's a perceived end-of-life situation. Because here's what's happened. Many ICU patients can't wean off the ventilator through the breathing tube in their mouth within, let's just say, 10 days, 14 days, right? Sometimes up to 3 weeks. That doesn't mean they'll never breathe independently again. It means they need more time. A tracheostomy, which is a small breathing tube placed in the neck, is often the key to reduce sedation so that your loved one can wake up and communicate. Reduced opiates, right? Pain medication such as fentanyl or morphine. A tracheostomy helps with better comfort, easier weaning from the ventilator, reduced risk of complications. Mobilization is possible, So, you're taking a conversation from your loved one is going to die to, hang on a second, maybe with a tracheostomy we can start mobilizing. Can you see the contrast? And it's not a contrast that can't be bridged. It's a contrast that can be bridged. But many hospitals might be reluctant to do tracheostomies because it signals a longer stay in ICU. It means that pressures on ICU beds mean they might need to move other patients along. ICU teams might assume the patient will need long-term ventilation, and they don't know about home care options such as intensive care at home. I'll give you another real-world example. A 45-year-old lady with COVID pneumonia. After 2 weeks, the ICU team suggested palliative care. She's not improving, they said. The family pushed back and asked about a tracheostomy. Reluctantly, the team agreed. Within 72 hours of getting the tracheostomy, she woke up because sedation and opiates could be stopped, started communicating via writing. Within 3 weeks, she was off the ventilator. Within 8 weeks, she walked out of the hospital, right? So, like I said, 70 to 90% of intensive care patients survive, right? So the odds are in your loved one's favor. Never forget that. Never forget that. And always ask the question, is it a real or a perceived end-of-life situation? So, what you need to do, if end-of-life discussions are happening too early and your loved one has been intubated less than 2 weeks, ask the following specific questions. Has a tracheostomy been considered? Why or why not? What specific medical reasons indicate my loved one cannot recover? Are there any reversible factors we haven't addressed? Can we get a second opinion from another intensive care specialist or another, neurology, special neurologist, or, whichever specialty needs to be involved? Write all of these down, take them to your next family meeting with intensive care teams. So, drop a 1 in the chat if this first sign resonates with you or if you've experienced this. And I know that many families in intensive care have experienced this. And if you need help navigating these conversations, this is exactly what we do at intensivecarehotline.com. We provide independent expert advice to families, making sure all options are being considered. Yeah, Luna, you're saying you have experienced this or you can resonate with this. When families are reaching out to us here at intensivecarehotline.com or at intensivecareathome.com, it's often why they do reach out to us as saying, oh, the ICU team has been negative. They want to stop treatment. They're telling us my loved one's not surviving. I give you a really strong hint here. If they're telling you your loved one won't survive, but they're alive today and they're alive tomorrow, and they're still telling you your loved one won't survive and they're alive the next day and the day after, you have to question the intensive care team's clinical judgment. You have to question their agenda. Always go in with eyes open. Okay, sign number 2. Lack of discussion about home ventilation and intensive care at home. So no discussion about home mechanical ventilation options, tracheostomy care with intensive care at home. This is huge, and it's where the knowledge gap is massive. Here's the scenario. Your loved one has a tracheostomy now. They're stable, but they still need ventilation support, maybe full-time, maybe just at night. And they've got a tracheostomy. The doctor says they'll need long-term acute care, or they need to go to a facility or a nursing home, or worst case, there are no other options. They have to stay in ICU indefinitely. This is where families lose hope. This is where many families agree to withdrawal of treatment because they think the alternative is their loved one is trapped in an ICU bed forever. But here's what ICU teams don't tell you. Evidence-based home mechanical ventilation and intensive care at home for both adults and children with or without tracheostomy is not only possible, it's actually the best option for quality of life in those situations. Let me tell you about the evidence-based mechanical home ventilation guidelines. Let me tell you about intensive care at home accreditation, third-party accreditation. All of that is very comprehensive and evidence-based mechanical home ventilation guidelines. I'm going to put the link in the description below. And these guidelines show that home mechanical ventilation is safe when set up properly, provides a much better quality of life than institutionalized and hospital care, allows for community access and normal life activities, is appropriate for both long-term support, for ventilation weaning, and also for palliative care if that is the patient's or the family's choice and becomes necessary. I can only emphasize here that all of our clients at intensivecareathome.com, adults and children on tracheostomy and ventilation without tracheostomy or tracheostomy without ventilation, have community access. They go to coffee shops, to the shopping center, to parks, to family gatherings. They live their lives. Compare that to end-of-life talk in ICU, right? And even if patients receive end-of-life or palliative care at home, they have a dramatically better quality of life at home than in an ICU or hospital wards. I can tell you that pretty much for all of our intensive care at home clients in our home care environments, all ICUs that those patients have come from would have had the talk to families about end-of-life care, about palliative care, saying, oh, your family member won't have any quality of life, they should just die, right? And here they are still alive and live a good quality of life, right? So you have to question everything. So why don't ICU doctors discuss intensive care at home at a large scale? 3 main reasons. Number 1, they don't know it exists. Home ventilation services like intensive care at home are specialized and not well known in mainstream ICU. They may assume it's not available in your area without checking. They assume families can't handle it, but they're not doing it alone because we provide 24-hour intensive care trained nurses at home, right? So let me tell you about James, who was born prematurely, and he was in ICU or in neonatal ICU and pediatric ICU for 10 months, needed a tracheostomy and ventilation. The hospital said, oh, look, as long as he's got a tracheostomy, he needs to be in ICU. But the family of this child found us, and we took James home and weaned him off the ventilator and the tracheostomy. And, James now goes to school. He has birthday parties. He goes on family holidays, without a ventilator, without a tracheostomy, because we managed to wean him off that. And, his parents are still reaching out here and there. And, they're still saying, the hospital made us feel like we're choosing a prison sentence, but now he has a life, and it wouldn't have happened without intensive care at home. He's now home with his siblings, his dog, his pets, his own room. Anything is possible. So if your loved one has a tracheostomy, or the doctors are saying they'll need long-term ventilation, ask the following questions. What are the options for home mechanical ventilation with intensive care at home? Can we get a referral to intensive care at home? What would need to be in place for my loved one to be discharged home with intensive care at home? And go to intensivecareathome.com for more information about intensive care at home. I'll put the link in the description again to the website for intensive care at home. Look at what's possible, right? And for anyone that's watching here right now, type 2 in the chat pad if you didn't know that intensive care at home was an option, if this is all news to you. So we're really getting to the heart of this right now. Let me move to sign number 3. Treatment limitations are being recommended primarily based on age or pre-existing conditions, not actual prognosis. It's a very sensitive topic, but we have to talk about it because it happens every day all around the world. Medical bias is real. Age bias is real. And it affects decision-making in ICU every day. Here's what it sounds like. Your mom's 78 years old, and even if she survives, her quality of life is poor. Or they'd be saying things like, oh, your dad had dementia before this, so he won't have any quality of life. Would you really want your dad to be around? Or they say things like, given your sister's disability, we don't think that she will have any quality of life or that she will have any meaningful recovery. Or they say things like, at your brother's age, the chances of a meaningful recovery are very slow. So let me be clear. Age and pre-existing conditions do matter for prognosis. A 25-year-old previously healthy person has a different trajectory than an 85-year-old person with multiple health issues. Let's not beat around the bush. But, and this is critical, these factors should inform the discussion, not end the discussion. The discussion should never be, is this person old or disabled? The question should be, what does this person and this family value? What would they consider a worthwhile quality of life? Some families might say, if dad can't play golf again, he wouldn't want to live this way. That's a value to hold. Other families says, if mum can be at home, recognize us, enjoy her grandchildren visiting, that's enough for her. She doesn't need to be independent. That's also a valid value. But when doctors make assumptions based on age or pre-existing conditions without exploring what the patient would want, that's when ICUs give up way too early, and they're biased towards whatever they're biased towards, but they're not biased about patient and family choice, which is what they should be biased about. Again, let's give you another real-world examples here. 82-year-old man with early Parkinson's disease, respiratory failure from an aspiration pneumonia. The doctor strongly recommended against continuing treatment. They wouldn't even mention a tracheostomy as an option, and then the family contacted us. We said to them, well, have they told you about a tracheostomy as an option to prolong life and give him a chance to wean off? And they didn't. The ICU team was trying to create the narrative of, well, your dad is 82, he has Parkinson's disease, and his quality of life will be poor. Well, what's quality of life? Quality of life is a perception about something. It's a perception. It's based on values. It's based on the person. It's not an objective measure. It's a subjective measure. How do you measure quality of life? Well, I measure it differently compared to you, right? That's normal. And that's how it should be. So this particular family, like many families, pushed back. They said Dad has always been clear. He wants every chance at life. He's still playing lawn bowls twice a week. His Parkinson's is mild. So he got the tracheostomy. And, a few weeks later, he came off the ventilator. And, he's at home now without a ventilator. And he's still enjoying life with his family. So what you need to do right now if you're in a situation like that, if you're hearing recommendations based heavily on age or pre-existing conditions, ask, are you saying treatment won't work medically, or are you making assumptions about quality of life? State clearly, this is what my loved one would consider an acceptable quality of life, and be specific. Ask, what would the treatment pathway look like if we pursued aggressive treatment? What are realistic outcomes? Request, can we try aggressive treatment for a defined period, i.e. 1 week, 2 weeks, 3 weeks, whatever the case may be, and then reassess. And also, as a bonus tip here, get an advanced care plan written up now. That's my recommendation for everyone. Look, I know these conversations are exhausting when you're already devastated and terrified. This is why services like intensivecarehotline.com exist. We can be your advocate. We can be in these meetings with you. We can push back with medical expertise when you're too overwhelmed. And let me know, drop a number 3 in the chat if you've experienced age or pre-existing condition bias in ICU decision making. Let me know. All right, we're hitting the halfway mark here roughly. Let me give you signs 4 and 5, and then we're going to pivot to the solution, what you can actually do about all of this. Stay with me. If you're finding this valuable, hit the like button again and drop a comment so YouTube shows this to more families who need it. And thank you, Luna, for letting me know that you've experienced bias, whether it's age bias or pre-existing health condition bias. There's probably not one family in intensive care who hasn't experienced that, sadly. Okay, let's move on to sign number 4. Discussions about withdrawal happen without exploring all treatment, all weaning, and all rehabilitation options. Quick scenario, your loved one has been on the ventilator for a few weeks. The doctors say they're not weaning successfully or they're ventilator dependent. First red flag, if withdrawal of life support is being discussed, but there's been no mention of gradual weaning protocols, different ventilation modes, tracheostomy if they don't have one. For example, BiPAP or CPAP ventilation without tracheostomy, specialized rehabilitation, home ventilation with intensive care at home as a bridge to weaning. Many patients who appear ventilator dependent in the acute ICU setting can successfully wean with more time, better nutrition, reduced sedation, proper rehabilitation, a less stressful environment like home. Questions to ask: what specific weaning protocols have been tried? Could my loved one wean in a different environment with more time? Has the pulmonologist or respiratory physician been contacted, and has respiratory therapy been optimized? Right? Type 4 in the chat pad if you didn't know there were different approaches to weaning. Now, let's move on to our last sign, and sign number 5. The hospital is citing resource limitations or bed pressures as factors in decision making. Listen carefully. Sometimes doctors will say things like, we need to make a decision about whether to continue aggressive care when bed pressures are high. Or they've been saying things like, your loved one has been here a long time, implying too long. We have other patients who need this ICU bed. Now, if you hear any of these, red flags. Now, the other thing that I should also list here that they're not telling you, but I know it's definitely happening, but they would never say that, is it's costing us too much to keep your loved one here. We're losing money. They're not telling you that. Now, I understand hospitals face real resource pressures, and I've been on the other side. I've worked in hospitals, ICUs long enough to understand the bed pressures in ICU. But here's what families need to know. Medical decisions should be based on what's best for your loved one, not what's best for the hospital, what's best for the ICU, what's best for the bed capacity of this ICU, what's best for the staffing situation in ICU. If you're sensing that pressure to move your loved one along is influencing medical recommendations, you need to ask directly, is bed availability influencing this recommendation? Request a second opinion from a different intensivist. Contact patient advocacy services in the hospital. Contact intensivecarehotline.com for advocacy. Document everything. Again, get independent expert advice, which is exactly what we do at intensivecarehotline.com. Here's the truth. Once you know about home care options, tracheostomy and ventilation at home through a service like intensivecareathome.com, the pressure to make a decision becomes irrelevant because you're not choosing between staying in hospital forever or withdrawing treatment. You're saying, move my loved one to home with proper ICU level support 24/7 to keep my loved one out of ICU permanently and predictably, and let's see what they can do in a healing environment. Right? Let me know if this is resonating with you. Type yes into the chat pad. Okay. And I can see that Luna also didn't know that there were different approaches to ventilation weaning. So it is, we're here, I'm here to educate, this is exactly why you are here. Right. This is exactly why we're here, so that you can get proper education about this topic to empower you. Okay. So we've covered the 5 warning signs. You know what to look for. You know what questions to ask. So let's now shift from problem to solution. So in the last 20 minutes or so of this presentation, I'm going to show you what's actually possible. Evidence-based home mechanical ventilation care for tracheostomy and ventilation with intensive care at home that most families have never heard of. So just give me 30 seconds. I just need to moisten my throat and then I'll be right back. Just give me 30 seconds. Okay. So now let's look into the home care solution, whether that's for long-term ventilation with a tracheostomy, whether it's for ventilation without a tracheostomy, such as BiPAP, CPAP, whether it's for tracheostomy care without ventilation, whether it's for home TPN, home IV potassium, home IV fluids, home IV antibiotics infusion, whether it's central line, peak line, Hickman's line, port management at home, or nasogastric tube, nasojejunostomy tube, PEG tube, PEG tube. If any of this, is needed at home, we can do all of that, including catheter care, SPC, IDC, and so forth. So let me tell you what we're covering now in the last 20 minutes. Evidence-based mechanical home ventilation guidelines for adults and for children. The evidence for intensive care at home. What community access actually looks like for ventilated patients. How home care provides better quality of life than ICU, even for palliative care. The practical steps to discharge home with tracheostomy and ventilation, and how intensivecareathome.com makes all of this possible. So I want you to imagine 2 scenarios. Scenario number 1, your loved one stays in hospital or goes to a nursing home, which is not really possible. But they're in a clinical environment 24/7, limited visiting hours, institutionalized care, shared spaces, noise, bright lights, no privacy, separated from family, pets, their own belongings, and a super high infection risk because they're in an institution. Let's look at scenario 2. A loved one is discharged home with a tracheostomy and portable ventilator. They have 24/7 intensive care trained nurses. They're in their own room with their own things, own belongings. Family can visit anytime. Family can live there. The dog can sleep on the bed. The cats can run around. Everyone can go outside. They can go to their children's or grandchildren's birthday party. They have dinner, can have dinner at the table with the family. Which scenario do you think provides a better quality of life? Which scenario do you think gives the better chance for recovery and improvement? The answer is obvious, and the evidence backs this up completely. Let me show you the evidence, and then I'll show you how it works practically. Again, I'm going to put a link in the written version of this blog once we've published it. To our mechanical home ventilation guidelines that are evidence-based. They are comprehensive evidence-based guidelines for mechanical home ventilation. They show safety. Of course, it has to be safe. Home mechanical ventilation, when properly set up with trained ICU nurses 24 hours a day, and appropriate equipment, is as safe as ICU level care. Quality of life, consistently higher quality of life, scores for patients at home, hospital versus hospital or ICU. Outcomes, comparable or better medical outcomes in many cases due to reduced hospital-acquired infections, better nutrition, reduced stress, more personalized care, better sleep quality. I mean, everyone that's been in a hospital knows that there's a disturbed day and night rhythm. People can't sleep, etc. Also, of course, family impact, reduced caregiver burden when professional support is in place, better family functioning. I can tell you, we have kept families together with intensive care at home. We have saved marriages. We have saved people from moving towards the poverty line, or we have people moved out of the poverty line because of our service, because people were then able to return back to work. Also, on a financial level, cost effectiveness. So if someone is stuck in ICU forever and a day, that costs between $5,000 to $10,000 per bed day, depending on the location, whereas home mechanical ventilation with intensive care at home is by far more cost effective than ICU level care, and you get the same level of care at home. It's about 50% of the cost of an ICU bed. So intensive care at home is definitely not experimental. This isn't fringe medicine. This is evidence-based, accredited, third-party accredited, guideline-supported care that's been proven in multiple countries now over decades. So why don't more people know about it? Because it requires specialized service like intensivecareathome.com that can coordinate not only medical equipment, 24-hour intensive care trained nurses. By the way, we are employing hundreds of years of critical care nursing experience in the community combined. Hundreds of years combined. No other service provider offers that experience combined in the community. And we're also the only service in 2025 that is third-party accredited for intensive care at home. No other service has got the policies, the procedures, the know-how, the intellectual property to make this happen. We obviously also have emergency protocols. We integrate the families into the care if they choose to. They don't have to, because we're there 24 hours a day. We obviously liaise with hospitals and GPs. We have a network of physiotherapists that are ICU trained or occupational therapists that know about home care. So we have a network. We also have our own ICU consultant, ICU doctor. So all of this exists, but many ICU doctors either don't know about them or assume they're not available to your situations. So type home care in the chat if you're starting to see the possibility here. So let me show you what this actually looks like in practice. Let me walk you through what discharging home with tracheostomy and ventilation actually looks like with intensivecareathome.com. So step one, assessment and planning. While still in ICU, our team assesses your loved one medically, and from a nursing perspective, we evaluate the home environment. We create a detailed care plan. We coordinate with the hospital team. We arrange all equipment and supplies. Then we look at the home setup, ventilation and backup equipment delivered, emergency equipment in place, home modifications if needed, but it's usually very minimal. And communication systems are set up. Next step is transitioning home, coordinated discharge from hospital and ICU. Obviously, our ICU nurse or ICU nurses accompany during the transport back home. 24/7 nursing begins immediately. And obviously, leading up to that would be the staff selection, where we get you involved. If you want to, you can select your own staff. You can be involved in selecting them if you want to. Then obviously as care begins at home, 24/7 ICU trained nurses, you're never doing this alone. Regular physiotherapy, a coordination with either ICU consultants or with your family doctor and other specialists, regular equipment maintenance, emergency protocols in place, weaning program if appropriate, and palliative care support if needed. And here's really what makes this different from institutionalized care. Again, community access and quality of life. I can't stress this enough. Every single one of our clients, adults and children, have community access. So what does that mean? For children, attending school with nursing support, birthday parties, park visits, family holidays, a normal childhood experience as possible. For adults, some of our clients can actually work. They go to coffee shops, they go to family gatherings, they go to the movies, they go to outdoor activities, social connections, they go to church, they maintain hobbies and interests and have meaningful relationships with others, whether it's family or friends. Also, we have portable ventilators, we have portable suction machines, we have emergency bags ready to go. We have experienced critical care nurses who coordinate the community access for our clients. This is not about being trapped at home. It's about having a home base while living. Again, giving you some examples here, a young male client of ours who's in his early 20s, got a C1 spinal injury, obviously as part of that condition is ventilated with a tracheostomy. He got discharged with intensive care home many years ago, goes to the movies, goes to see friends, goes shopping, goes to see other family members, and is living a good quality of life. Another example is a 10-year-old girl who's got a neuromuscular condition, needs actually BiPAP ventilation, needs a cough-assist, doesn't have a tracheostomy, thank God for that, has been discharged home also with 24-hour nursing, and now attends specialized school, goes on family vacations, has a much better quality of life than in a hospital or that a hospital could ever provide, right? I can also give you another example, a 51-year-old man with an acquired brain injury. It's not ventilated, doesn't have a tracheostomy, but needs a cough assist machine, needs airvo, breathing support, spent basically 1 year in hospital. They couldn't discharge him, not permanently anyway. And since we started there, would have been August 2024, he has been home ever since. And then I also want to give you a quick palliative care example. We had a client a few years ago. He was stuck in ICU on BiPAP for end-stage lung cancer. And we took him home for the last 3 months of his life. And he never, ever wanted to see a hospital ever again. And he had end-of-life care at home, and he was surrounded by family in his own bed with his cat, watching the cricket, was still eating a little bit, his wife's cooking, and the family said that it was a gift to have that time at home instead of in intensive care. And the last example is so important because even for end-of-life care, even for palliative care, home is the much better option than hospital. It comes down to dignity, comfort, family, privacy, peace of mind. All is possible with the right support with intensivecareathome.com. Now, I know what some of you are thinking, but what about emergency situations? Well, again, 24/7 intensive care nurses are trained in all emergency protocols. Backup equipment is always in place. Emergency services and backup options are pre-coordinated. And, the other thing that I want to emphasize here is, when we hire staff, and I'm still involved in interviewing staff, we ask them one important question: what do we need to do today to keep our clients at home tomorrow? Right? What do we need to do today to keep our clients home tomorrow? It's a very important question to ask. And again, we have that skill set to make that happen. Now, I also want to know, you ask about the cost Cost is often covered by insurance or healthcare funding. In Australia, it's covered by NDIS or other funding bodies, whether it's private or public. Department of Health. We help navigate the funding options because we understand the funding landscape. Even if you are privately paying for a hospital bed, again, you can cut the cost here by 50%. Again, go to intensivecareathome.com for specific information. But what if my family can't handle it? You're not doing the medical or nursing care. Our 24-hour nurses are doing it. Family can be involved or as uninvolved as you want. It's entirely up to you. We can provide you with training for whatever level of involvement you choose, but you never have to take full responsibility, because it is, at the end of the day, it's intensive care nursing where you need years of training and experience. But this is really about having a loved one home, not about you becoming a nurse or a doctor. So drop in any questions or concerns in the chat and I'll address them. Now, all right, let me bring this all together with the practical action steps you can start taking today. So we've covered a lot in the last 50 minutes. Let me make this super practical for you. If you have a loved one in intensive care right now, action step number 1, get independent expert advice. Go to intensivecarehotline.com. This is our service where we provide independent expert ICU advice to families. We can review your loved one's medical situation, attend family meetings with you, virtual or in person, provide second opinions, advocate for appropriate treatment, explain all your options clearly, and we challenge the intensive care team on every level that you want us to. Because you don't need to navigate this alone. You don't have to accept everything the hospital says without questioning. Get expert advice, get expert support. Ask the question we've covered today. Go back and watch this video again or read the description where I'll put key questions. Take these questions to your next family meeting about treatment. Has a tracheostomy been considered? What specific medical reasons indicate recovery isn't possible? Are there reversible factors we haven't addressed? What would aggressive treatment look like for a defined period? Ask the questions about intensive care at home. What are the options for home mechanical ventilation? Can we get a referral to intensive care at home? What would discharge home with ventilation look like? About decision making. Is bed availability influencing the ICU team's recommendation? Is the ICU team making assumptions about quality of life based on aged or pre-existing medical condition? What have other patients with similar presentations achieved? Request assessment for home discharge. Contact intensivecareathome.com directly. Even if the hospital says it's not possible, get our team to assess the situation with discharged patients home that hospital said couldn't be discharged in the early stages of their ICU admission. Also very important here, get access to all medical records so that we can give you that second opinion. Get access to all medical records. Document everything. Keep notes of all family meetings. Record what doctors say. Or write details notes immediately after. Document all recommendations and your questions. Get things in writing when possible. Build your support team. Connect with other families going through this. You can find communities online, or we can set you up with other families who are going through this. Identify family and friends who can help advocate. Consider engaging a patient advocate or medical legal advisor if needed. Use professional services like intensivecareathome.com. And Luna, you're asking if we're serving people in California. Yes, we absolutely do. So what I would like you to do is either contact me after this video, send me an email to, I'm just typing the email address in the chat pad, or you can call me. So you can email me here, or you can call me on, this is my US number. I'll type you 415. You can call me here on this number. Okay. So are there any other questions before we wrap this up? But what I want you to take away from today, you are not powerless. You have options. The hospital's recommendation is not the only path. When doctors say there's nothing more we can do, that often means there's nothing more we want to do in this hospital. That's what it often means. there is something more that can be done. Evidence-based mechanical home ventilation guidelines with intensive care at home and with proper support can and will provide more time for healing and recovery, better quality of life, community access and normal activities, dignity and comfort even in palliative care, and hope when the hospital has given up. So contact us at intensivecarehotline.com if you need immediate support, and if you want to explore home care with intensive care at home, go to intensivecareathome.com. And if you want ongoing education, subscribe to my YouTube channel. Again, like the video, click the notification bell, and share the video with anyone who has a loved one critically ill in intensive care. So once again, with intensive care at home, we are also providing level 2 and level 3 NDIS support coordination and TAC case management in Victoria. And we are an NDIS approved service provider, and we are the only service in 2025 that is actually third-party accredited for intensive care at home. Now, if there are no other questions, I'm going to wrap this up now. I'll do these YouTube lives every week around the same time. Let me know what topics you want to have covered, and I'll provide on them. Have a wonderful weekend and have a happy new year, and stay safe, stay healthy. Take care for now. Thank you so much.